Hello, Ashwini. Evening.
Yes, sir. कैसे हैं?
Yeah, how are you?
Good evening. बस चल रहा बस.
बस ठंड का मजा ले रहे हैं. So cold.
हाँ, बहुत ठंड है बहुत.
बहुत ज्यादा ठंड है. और how are you?
Hey, much better.
Better.
आजकल क्लिनिक में पेशेंट भी नहीं आ रहा है. हाँ,
Very few patients. काम कम ही कम है.
कम है ही. और कलकत्ता चल रहे हो ना आप?
AIOS.
हाँ,
AIOS के लिए नहीं. I'm not going. Not. I'm not going.
अच्छा.
Good evening, everyone. This is day 2 of the Golden Jubilee series that I have planned for over 2.5 months, 3.5 months, almost 3.5 months. And the intention is to uh, teach and, teach the PGs, teach the young postgraduates who just passed out or who are in training or doing fellowship somewhere. So all types of eye surgeries will be uh, shown, and they are all unedited. So it's kind of deferred life surgery. So today I'll be showing mature cataract. So one can manage a mature cataract. So this is a patient with a mature cataract. You can see absolutely white cataract, and starting the surgery with making the side ports just a little away from the limbus. The two side ports are made using a MVR blade, and one stabilizes the eye by using a skin's forceps. Then put air inside the eye and your trypan blue. The air basically protects the corneal endothelium from any toxic effects of the trypan blue that may occur. And I always do this. I inject trypan blue from one side port and I wash it from the other side port. The reason being that uh, the side port incisions tend to get lost. Why is it showing 10 minutes? Side port incisions tend to get lost, and one starts looking for it with the chopper. Then the incision, main incision, groove is made with the atom, and then one takes the 2.2. This is a 2.2 blade, and one takes the blade for about 2-3 millimeters into the cornea and then into the anterior chamber. It's injecting some more viscoelastic in the eye. Then my preferred technique of doing rhexis is puncture the anterior capsule and aspirate whatever liquid cortex that is there, and also press the nucleus slightly so as to squeeze out whatever uh, liquid cortex that there may be behind the nucleus also. It is mainly done to prevent the Argentinian flag sign. Using a rhexis faucet. This is Dr. Aldipurkar's rhexis faucet. Now, the aim is to not make a large rhexis to start with. Slowly, and this is an onion peel kind of rhexis. So there are many variations of this, but this is my preferred technique. So once we've made a smaller rhexis, then this strip of uh, interior capsule is taken all around. The spatula aids to give better visualization because it gets uh, picked up in a particular place. So once we've achieved a enough rhexis, 5 or 5.5 millimeters, that is good enough.
Mummy.
If this is good enough to give you space to perform your phacoemulsification. This is basically a flared, slightly bent, and now what you see in my left hand is a sharp clipper. So we begin by impaling the phaco into the nucleus, and once the tip of it disappears within the substance of the nucleus, then we initiate the vertical chop with horizontal separation. So while we are holding the nucleus, this maneuver has to be done. And if it slips out, then no problem, you can do it again. So try and propagate this back right till we can. Don't do a large lateral separation. So just enough. If it doesn't crack the end, doesn't matter. But if it does, then good for you. In this case, I didn't perform any hydrodissection because there was liquid cortex, and of course the nucleus is free. Once we've got all our different thighs, then we take one eye at a time, try and chop it again, and each pie is then emulsified. One should try and be in the skin of the iris so that uh, prevent any corneal injury, any endothelial cell loss uh, should be prevented as far as possible. So although this was a mature cataract, but the nucleus wasn't very hard, and you can see that all the fragments are coming out very easily, being emulsified very easily. Not much power is required.
ठीक है मन कर मेरा तो हो गया लगाई हो जाते हैं देखे फोन ऑन है ये आपका वो ऑफ है क्या नाम है एक मिनट इसको ऑफ कर दें
So as I normally always do, inject viscoelastic from the side port whenever I bring my phaco tip out, just to maintain the anterior chamber. Now this is a bimanual irrigation aspiration, and a little cortex that is remaining in the capsular bag is filled with the aspirating probe and brought into the center and then aspirated. And as I had demonstrated yesterday also, the irrigation always follows the aspiration in whatever area the irrigation is going, so as to not catch the posterior capsule. And one need not bring one's hand out and exchange the bimanual always. So usually we can manage to remove all the cortex from one side itself. A little bit of capsular polishing, whatever strands that are there. And this is just a little trick to try and remove whatever strands that are there. The little bit that is remaining, we can remove after implantation of the intraocular lens. Again, with viscoelastic being injected to the side port. And this is a very essential step that one must learn, because when one has a posterior capsular rent, the most important step in a rent is how to inject viscoelastic to the side port. So if you do it routinely, then it doesn't become too much of a pain while we have to do it when we encounter an complication. So this is a hydrophobic IOL with open haptics. Always load the IOL myself, and then using the traction being provided from the side port and a wound assisted delivery of the intraocular lens into the capsular bag, and then dialing it into the capsular bag. Then whatever little bit of cortex that is there can be removed. And a bit of capsular polishing can also be done.